that the lung transplant is a stress test, whether the country is ready to take on such a challenge of multidisciplinary management of a patient. So I'll just start briefly. During the early days of the war, I was invited to teach trauma, chest trauma, particularly in 3 different hospitals in Ukraine. And it was very shocking to see things on the freeways. During the trip, I had a conversation with Oksana Dmitrieva and VASYL STRILKA, who is here. And I was approached about specifically transplant effort. And I was shocked, why are you interested in lung transplant, your country at war? And they had actually a reasonable argument that a country lost this expertise of sending, or possibility of sending patients to Belarus or India for transplants. And such a big country needs good, robust transplant expertise. And the outcomes varied from place to place. Lung transplant didn't exist independently. There was a need to streamline the process and to have expertise and have a robust care for these patients. So there were some transplants in Lviv. Polish colleagues came and they transplanted first lung there with the Ukrainian colleagues. Then Ukrainians did their own transplants, but without ECMO, which is very limiting. Maybe 20% of lung transplants can be done safely without ECMO. So it was very, very selective group of patients. And so we selected a team, VASYL STRILKA and me, and with some help, we decided to choose some thoracic surgeons, cardiac surgeons. But that was a minor part. What we were focusing is to bring cardiologists, pulmonologists, ECMO specialists, anesthesiologists, coordinators, pathologists, so that it's a multidisciplinary approach, how it's done in such cases. And so this team arrived, 13 people, in October of 2022. And so the objectives of this observership was that the team would be split into different subgroups, and some would follow, cardiologists, some pulmonologists, go to the clinic, go on the organ harvest, go to the listing meetings, understand the whole ins and outs of how the patients are chosen, and then not only just technical details of operation, but also the whole decision-making, which patients are candidates, which are not, how do you select donors, and the whole expertise was, is taught. And so this is some pictures where they went on an organ harvest. I was one of the implanting surgeons, so I was explaining in Ukrainian how cuffs are prepared and this and that. So there was a great time. We obviously became friends with the faculty and took them for dinner. ANDRII, I think, missed that. He had to return earlier. They made a little piece in NPR about this crash course. And so what we were trying to teach was the systematic approach, not only in selection of patients, but also how to use ECMO and have no limits in a transplant, and know when to do it without ECMO, on a heart-lung machine with ECMO, just the whole expertise of that. And the importance of ECMO was that with the ECMO, you drop the pressures in the pulmonary artery, the rate of the pulmonary graft dysfunction drops down, and it's the most safe way of doing ECMO. And we were trying to teach them that sort of part of the lung transplant effort. And so when they came back, they did the first transplant was a 50-year-old with a COPD and some interstitial lung disease. So he was listed in December, and then later on he got he was on 8 liters of oxygen. Here's his CT scan. As you can see, lungs are severely diseased, end-stage disease. So he was transplanted in March of 23, and technically the surgery went flawlessly. Cardiac surgeons did vascular anastomosis, thoracic surgeons did bronchial anastomosis. So that part went MGH style, ECMO, in and out. There was not much to add. Patient was extubated. However, So he was walking and actually went home, had some infections. What I heard from the surgeon team, there was a recurrence of ETUH use, and he eventually succumbed to pancreatitis. So first lesson learned, social work, social support, that's an issue. Second transplant was a 32-year-old female with LAM, young mother. And so she was also on 8 liters of oxygen. This is a disease, that end-stage lung disease. You have to do lung transplants. There is no other way out. And those patients exist in Ukraine. Cystic fibrosis, LAM, ITP. What do you do with those patients? End-stage disease, young patients, parents of kids. They have to have a way out. They have to have a functioning team who can transplant the organs. So the lessons from this early stress test, yes, early result is good. Technically, it's feasible, it's doable. But because of the complex system issues, which I want to touch on, I would say that stress test a little bit failed. And so we need to kind of think again. And this is not first time. As you remember, when the heart transplant was introduced in America, Stanford was doing a lot of heart transplant in 67 to 74, and then we realized that we have a huge mortality. Some people would survive 6 months and would die because there was no cyclosporin. So there was a moratorium, no heart transplants anymore. America had to reassess. And then in 1980, when cyclosporin came, heart transplant took over again. So this is nothing new. When things happen, you have to reassess and build up. So first thing is selection committee. It's not just surgeons. Surgeons are a minor part of this. Technical, as you can see, Ukrainians are gifted surgeons, very committed to their patients. They can deliver that. But it's only one part of the equation. The bigger part of the equation is who is the captain of the boat. The boat usually in America, as we know, it's a treating physician, cardiologist, pulmonologist, who treats these patients longitudinally. They select these patients, bring the transplant, surgeons do the job, and then they come off that ship, and then the pulmonologist or cardiologist, they lead these patients longitudinally, treat complications, and they manage that. So there is also a lot of social work, psychiatry, nutrition, financial coordinator, where the patient has money for the bus to go to have a biopsy, where the patient has enough support to do during complications, and all these infectious diseases. It's a huge committee work. It's not just surgeons and physicians. The other things is this issue of infection, and we heard a lot about that today, and I just wanted to touch only briefly. There is a lot of failures, non-rejection related deaths, and that's because of infections. As you can see here, it's not only heart, it's other organs. So it's a ubiquitous problem. A lot of these gram-negatives are multi-resistant drugs, and I don't want to stop much on that. As we know, there is a new strain of Klebsiella. It's called Ukrainian Klebsiella, which is resistant to everything. And as you can see here, this is the example that ID physicians are dealing with. And imagine this patient has a transplant and this kind of bug in the lungs, and you cannot treat that pneumonia. So next effort that we had to do was to bring some specialists from Ukraine to learn the ID control efforts from different nephrology, pulmonology. So that was, these individuals came, learned. We brought also the surgeons from Lviv again to learn the transplant on ECMO because they didn't have that expertise. So we kept trying. And then, as you can see, there are different hospitals, and so transplants do happen in Ukraine, and it's a viable option. The lung transplants were done in Feofania, that RIG 2023, you can see in yellow color. So expertise is there, but we just need to have a better system. So I just wanted to go briefly through the story, but for the discussion point, there is definitely a need. There is no way out for Ukraine to have not to have such independent program. Lung transplant is the hardest. The heart is actually easier. It's a pump. A lung transplant is the hardest because it's, first of all, it's very hard to find organ for lung. They have to be managed nationally very well because they usually flood with fluid and they're not well sanitized. So by the time donor organ is listed for the donation, those lungs are not usable because they're just flooded with fluid and pneumonia and pus. So the management of organs is very difficult. Also the program leadership. Yes, initially, whenever those programs start, it usually goes on the shoulders of surgeon, but the long-term goal is to have it as a pulmonologist or the cardiologist who leads that. He's the captain of the ship. We are technicians, and I'm saying that as a surgeon, and because that's the best thing for the patient. The needs of the patient come first, as we know. Also, this system issue of ID control, as you could see, and Haley was extremely good in this issue. We all saw how big this problem is in Ukraine with the multi-drug resistant patient organisms. Also, the transplant patients are some of the most difficult to manage. They are very sick. They require a lot of surveillance. They have complications, and so they have to have a dedicated, competent team that takes care of them. They don't need many programs. They need one or two, but it has to be national effort to build that team and maintain it so that they have one or two transplants every month, so that the expertise is there. It's like playing in an orchestra. You have to have practice, otherwise you lose the expertise, team goes apart, and patients suffer. And it's not only surgeons and physicians, it's also social work, physical therapy, nutrition, coordinators. The whole system has to run like a well-oiled machine, and it's a national need to build that. And also, as we heard from Natalia also, there is a huge need to improve the nursing care. There is need for nurses and multidisciplinary structure of taking care of these patients, and non-MD layer of physicians, layer of providers has to be there. And then one last thing I want to touch, there is definitely this need, and it being touched again and again, about the self-regulation within specialties. Some specialties, for example, infectious diseases, in America it's a well-respected specialty, and there are subspecialties like ID control. In Ukraine, ID control doesn't exist because the specialty itself is not well regulated. So once you build a good basis where each specialty, like cardiology, is built, then you can develop heart failure cardiology and so on and so on. And this subspecialization, whatever is needed, needs to be talked about, and people have to organize and build good, competent teams of experts in the country who define the quality of care of the patients. And it has to come from within specialties. And good residency training, thoracic surgery training is 6 months. That's not sufficient for lung cancer, lung transplant, esophagus disease, trauma. It's way too short. And we all know that in America and Europe. And so Ukraine has a lot to do, but a lot of it should come from the subspecialty within. Thank you. So I will join the panel and we'll ask some questions. But if somebody has a question, you can think about that already.
Okay, maybe.
So I will ask question first to ANDRII. Looking back at that period, you've been there, you've seen this. What would you do different if you had it again? Like what was lacking? Where do you think the program? Where do you think the process didn't work as we thought it should?
As for me, thank you. As for me, it's the most difficult question for answer. I'm ANDRII STROKAN. I'm a doctor anesthesiologist and chief clinical medical officer in Feofania hospital. Maybe it's the first conference in my life where all of the participants said about the negative characteristic of Ukrainian medicine. It's a very specific for our nation, really. Because in this 3 years of this war, our hospital performed 20 liver transplant, 3 heart transplant, and 2 lung transplant. Unfortunately, war is a catastrophic situation for people, for family, for nation. But war, this war, it's really true, opened the gate to Ukrainian specialists to other civilization world, especially for young doctors, for young people who want to change the situation in our country, and they really change the situation in our country, especially in medicine. We have two very difficult for understanding things. If we treat patient with military trauma, or maybe we treat patient who needs a special type of treatment, it's a transplantation. In Ukrainian, we have a lot of hospital, really. We have a lot of hospital, but unfortunately, we don't have enough adequate hospital with very good specialists. Now we have the situation, the specialists who have a very good knowledge and skills for treating patient with military trauma take part in transplantation. It's two impossible things because we don't have a good hospital. Why? 4 years ago, 40, 50, 60 years ago, where the biggest Ukrainian hospital constructed, we don't know about the Klebsiella. I do not know maybe the 5 hospitals in Ukraine who have ward for one patient, in Kyiv, for example, for one patient. Our ward includes 4 patients, 5 patients, 6 patients. It's not possible to perform some special surgery in these conditions. And it's so funny. It's a very interesting characteristic for Ukrainian medicine gave my friends, Leo Krivsky. Maybe in this audience some of us know this guy. It's a Russian original guy who crossed the Atlantic Ocean in this year to support Ukrainian medics and especially our hospitals. He worked as a thoracic surgeon in Southampton in Great Britain, and he collected a lot of different humanitarian supplies and gave for our hospitals, and flag from this ship now stayed in our audience, in our hospitals. And he said very interesting phrase. You are very interesting guys. You do not have a good skills to ride the bicycle, but you fly to space. As for me, it's a very good characteristic for Ukrainian medical facilities and Ukrainian doctors. Is it a bad? I think no, because it's a characteristic of our enthusiasm, how we do in these very difficult conditions, and what we perform. Can I change something in my hospitals after this period of time? I don't know. For these 2 patients who pass away after the half year of transplantation, it is not possible to change the global system of our medical health, because this patient have a special contact with medical system in different hospitals, and both of these patients are infected between hospitalization in our hospitals. And it's not, yes, we isolated 2 patients. It's we have a special ward for these 2 patients for transplantation, but patient needs some healing in other Ukrainian hospital, and it's not possible to prevent this infection. It's very difficult. What we need for the next development of transplantation in Ukraine, of course education, of course knowledge, of course skills, but we need to change our system of health, and despite the war, we need to, as for my personal opinion, we need to build the new campuses, special surgical campuses, and we are talking about not only transplantation, we're talking about the reconstructive surgery. For example, in our hospital, in my surgical campus, we have 6 operation theater. 6. Every day we have from 25 to 35 surgeries. 3 operation theater worked for patient with military trauma. 2 for patient with infected different situation. It's a typical surgery because the standard situation, the patient from battlefield zone, where I received patient from battlefield zone need maybe from 10 to 20 operation per period patient stay in our hospital. And the third operation, it's a operation for reconstructive traumatologic surgery. The next operation for patient with civilian diseases, it's a civilian patient, because now in Ukraine we must to earn some money for our function. Okay. I'm sorry. It's a very long, maybe very long speech and a really difficult question. And our hospital concentrate now for military trauma because we received most difficult cases from battlefield zone, and we have a very good specialist for treating patients. Transplantation, yes, it's important, but we need a special environment maybe for this case if you want to have a good result.
Yeah, that's heroic work that you do, and obviously what we heard, the infections were transmitted from the wounded soldiers to the patients, so it's a complicated cross-infection. Vasyl, anything to add from your side?
I just want to add that situation is different in different hospitals. For example, in Feofania, they really have problem with a huge number of severe cases. Have problem with a huge number of severe cases, military personnel, but for example, is the First Medical Union in Lviv. They are the biggest medical facility in Ukraine. They can manage both and military trauma and perform transplant with good result. But we also look on the transplantation. Transplantation have good side effects, because if hospital want to perform transplant, it should change situation in ICU with infection control and etc. And transplant, and if you the K from transplantation is in the ICU, we cannot perform. We haven't donors without good ICU, etc.
That's why I call it stress test. If country can do transplants, they can take care of very sick patients, and that's a very test of the system if it can maintain quality of care on such high level. And
about money, yes, we pay enough. All transplant in Ukraine covered by government, and the amount of payment is enough. We haven't nothing out of pocket payments for transplantation, but the all amount of money which we spend on transplantation in Ukraine still the lower than we spend and pay abroad.
Yes.
So, but we can perform the biggest number.
Good, thank you. I think you will succeed. I mean, there are many specialists around the world who want to help and to share the expertise with Ukraine. But right now it's tough times. But it will. I think by moving the transplant forward, you will also improve the care overall. Because when you can take care of transplants, you can also take care of the other sickest patients as well. So it's improving care overall. Thank you very much.
Thank you.